Hello, Saravanan.
Yes, sir.
Good evening.
Good evening, sir.
Only 3 of us have come. Is it 8:30 already? Not yet.
8:22, sir. We'll wait till 8:30. 8:30.
Okay. Okay. No.
Good evening to one and all. We are from Institute of Child at Madras Medical College, the Department of Neonatology. We like to present an interesting case. I am myself Dr. Saravanan, DM resident at ICH, and the moderator is Dr. Kamalarathnam sir, is HOD and Neonatology.
Okay, Saravanan,
Yes, sir.
welcome.
Welcome.
Go ahead with your case presentation and then we'll have a discussion.
Okay. History. It is a second born term female child, 38 weeks, with birth weight of 3 kg, apparently normal neonatal transition, which presented on a day 10 of life with respiratory distress and cyanosis of all 4 limbs. And there is a history of second degree consanguineous marriage, and there is also a history of sibling death, which is a male child at 2 months of age due to ARDS. This child was been symptomatic since the 15 days of life, which having respiratory distress. And also there is a history of bad child rearing practices. Like nose blowing was present after a birth. After that, the baby developed respiratory distress. The antenatal history was uneventful, and the birth history was normal vaginal delivery, and the baby had a normal neonatal transition. And family history, apart from the sibling death, there is no significant family history based on the third degree pedigree. There is no affected family members. On examination, the baby had a Downey score of 4/10, and with saturation of 84% on room air, and baby was maintaining with HFNC of 30% A5O2, 94 to 96%. The air entry was equal both the sides, and rest of the systemic examination was the normal limit, and there is no dysmorphic phases. Investigations, the X-ray showed a right upper lobe collapse consolidation, and the echo was done, which was showed a normal, structurally normal lot, and CBC done, which showed a HB of 16.8 with TLC of 8,000, and the differential count was not available, and the platelet was 1.46 lakhs, and CRP was positive, and the blood culture was sterile. Repeat CBC also has been done, which showed a TLC of 5,800 with no differential counts available. This was the X-ray at the time of admission, which showed a right upper lobe collapse consolidation. This baby actually presented on day 10 of life with respiratory distress and cyanosis, the nearby GH. They treated as a sepsis with pneumonia and given till antibiotics like peptase and amikacin, and they given antiviral Tamiflu also. But in view of persistent distress, they referred to us the ICH, and no improvement they referred. And here the baby had persistent respiratory distress, and there is also a history of sibling death with similar illness. There is a history of bad CRP. So in view of no improvement, we started on second line antibiotics like Miro and vancomycin. And in our investigations only, we will like right upper lobe collapse consolidation and CRP was positive. We initially kept it as an aspiration pneumonia since there is a bad child rearing practices like nose blowing. After that only baby become symptomatic. Then we kept it as a second possibility as immunodeficiency, as there is a persistent consolidation which is not resolving to the routine antibiotic usage, and there is a similar illness in the sibling which resulted in a early infant death. In view of sibling death, the resident has done a TMS which showed increased deoxyadenosine, which is of 14.5. The cutoff is less than 0.10, which is suggestive of ADA deficiency. This is the TMS report. In that they are given other condition like adenosine deaminase deficiency, which can be a possibility of severe combined, and they given a false positive rate like in severe infections and sometime in caffeine usage also. So we worked up based on suspecting like immunodeficiency. So then we ordered for a peripheral smear. Meanwhile, we got our peripheral smear, which showed absolute lymphocyte count of 19,920. The cutoff is 2,600 to 7,770. The latest peripheral smear, which done after 15 days of admission, which showed a ALC of 150. And we get back to our X-rays, which was done here and also in the previous hospital. There was no thymus shadows present, and USG chest also we have done, which showed absent thymus. In severe infection, like in steroid urease, there will be involution of the thymus, which can be seen. So ruled out also. Then we confirmed the mother's HIV was negative, since HIV can also cause us both T cell and B cell hypogammaglobulinemia, and we ordered for the lymphocyte subset analysis. This was the lymphocyte subset analysis done by using the flow cytometry, which showed a CD3 count 904. It is reduced based on the reference range, and CD4 also very much reduced. It's 11.7. CD8 is in the lower limit of normal, and CD19 is also reduced, which 4.52. And CD16 and 56. This is for NK cells, which is also in the lower limit of normal. And total CD45, which increases the lymphocyte progenitor, which is about 1389. So we have both T cells and B cells reduced, and we also have a NK cell, which is on the lower limit of normal. This was the flow cytometry has been done. And then we ordered for the immunoglobulin profile, which showed almost all the immunoglobulins were reduced compared to the reference range. IgG was 103, IgM also reduced, IgA also reduced, IgE also reduced. Since in severe combined immunodeficiency, we can have transplacental transfer of immunoglobulins like IgG. We can have a normal limit also, but in this child it was severely reduced. Then we obtained a pulmonologist opinion, and they advised to do a HRCT and plan for a bronchoscopy. The HRCT is mainly they want to rule out any evidence of ILD, since the pulmonary alveolar proteinosis and been reported in severe combined immunodeficiencies. But it showed only right upper lobe consolidation, probably of infective etiology. We have persistent collapse. We plan for a bronchoalveolar lavage. In the bronchoscopy examination findings itself, it showed a vocal cord candidiasis, and ball culture has been sent for CMV, which showed a PCR of more than 1 lakh copies, and bacterial culture revealed a Streptococcus pneumonia, significant growth, and fungal culture revealed a Candida albicans. We had hematology opinion and started the baby. Meanwhile, we started the baby on antibiotics like vancomycin, which is sensitive to the Streptococcus, and antiviral ganciclovir and antifungal oriconazole. Since we suspected a severe combined immunodeficiency, we given a IVIG 1 dose and followed by a subsequent dose within the 3 weeks. And we started the baby on Septon prophylaxis. We planned for the HLA typing of the child and parents, since the sibling was not available. Then we planned a NGSN exome genomic sequence, next generation sequencing to confirm the ADA deficiency gene mutation. And further plan we made it as HSCT once the current infection improved, and to start the baby on Septon and fluconazole prophylaxis. So we kept a probable ADA deficiency SCID. The points in favor, there is a family history since the first child was the male child and second child is a female child. That is of autosomal recessive inheritance, and there is also a favor of opportunistic infection like viral, fungal. Also had a bacterial infection, and a TMS, which is suggestive of ADL levels, which was very low, and increase deoxyadenosine, and both T cells and B cells were reduced, and immunoglobulin profiles have been reduced, and the NK cells were in the lower range of the limit. This was the subsequent X-rays at the day 45 and day 60 of life. The baby, ultimately the distress worsened and the baby developed shock and ultimately developed another sepsis, and the baby died around 60 days of life. This was the HLA typing the meanwhile sent. It showed you can see the locuses 1 and 2, and this will show about the site. You can have the class 1 and class 2. In class 1 you can have HLA A, B and C, and class 2 you can have DRB1, DQB1 and DPB1. They out of HLA A, B, C, DRB1, DQB1 can be taken. Like 10 by 10 is the absolute match, and if there is no siblings and all, means we can go for the unrelated donor. Since the father and mother, there will only 50% match will be present. The child gets from both father and the mother. In this child we had about a 7 by 10 match was there. So we meanwhile we planned, but the baby has been expired. Move on to the approach to the primary.
Saravanan.
Yes, sir.
Okay. Now, in your history presentation,
Yes,
anyway, now that you wanted to say something, should we discuss about the history and then go on to the discussion part, or you want to finish off the discussion also?
We can
finish
the discussion. Sir.
Okay, finish off the discussion.
Okay.
Okay.
The approach to the primary immunodeficiencies. We usually have like unusual site and recurrent infection, unusual severity, and unusual pathogen, and there is a family history. This is a cycle. The agent presentation, usually considering the neonates like 0 to 6 months, like severe combined immunodeficiency, leukocyte aggregation defects, Tay-Sachs syndrome, X-linked hyper IgM syndrome, and Viscott-Aldrich syndrome. The next 6 months to 5 years, we have chronic granulomatous hyper IgE, celiac eye gases syndrome, and more than 5 years, we can have X-linked A gamma globulin and common variable immunodeficiency. Approach to a T cell defect, as there will be mainly a severe viral opportunistic infections will be like viral infection, candida, fungal infection, or recurrent cyanopulmonary infection. First, we want to rule out is the HIV. Then we want to go for the lymphocyte subset panel and lymphocyte antigen mitogen proliferation panel. This, if you have only low T cell and low lymphocyte antigen mitogen proliferation panel, we can consider skip. Otherwise, if you have abnormal phases and hypocalcemia, means we can go for Tay-Sachs syndrome. If there is abnormal response to candida, means then we should go for chronic mucocutaneous candidiasis. These will present as a T cell defect. And SCID, it is a heterogeneous group of disorders with a deficit in T cell immunity, often leading to the additional impairment of B cell function and NK cell function. The incidence before newborn screening is like 1 in 2 lakhs live births, whereas the incidence now is currently 1 in 58,000 births. In countries with consanguineous marriage like Saudi Arabia, Southeast Asia, where the incidence is as low as up to 1:5,000. Usually, the severe combined immunodeficiency usually present after the 3 months once the maternal immunoglobulins get vanished. But we can have as early as presentation also. It is most commonly due to a 50% due to X-linked mutation, the gene encoding for the gamma chain. It is like IL-2 gamma. Then remaining 50% is autosomal recessive, in which the 40% are ADA deficiency and 25% are JAK3 deficient. There is something called Oman syndrome leaky SCID. In this, there will be function will be counts will be almost near normal, but the function will be very much reduced. And there is which will see it in later slides. And there is a maternal T cell engulfment. Usually there is no transplacental transfer of T cells, but if the baby's T cells is reduced, there will be maternal T cell transfer, which result in maternal T cell engulfment syndrome, like during HSCT or once the baby develops severe infections. This is a classification developed by IUIS in the 2008, like International Union of Immunodeficiency Societies, where there will be everything. There will be T cells will be reduced. If the B plus and NK is negative, means IL2R gamma JAK3 mutation. If T negative B plus NK plus means IL7R CD3D CD247. If T negative B negative NK negative, there will be ADA PNP and AK2. If T negative B negative whereas NK plus means you can have RAG1 and RAG2 mutations. Start about the newborn screening, which is TREC. TREC is a T cell receptor excision circle, which is developed by Chan and Puck in 2005. It was recommended by the US Department of Health in the year 2010. As of now, there is about 47 states in the US has been using, and also in some Canadian populations also they were using. This is the gene necessary for the creation of variable T cell receptors, which undergo splicing in the thymocytes. It's mainly formed during the naive T cell production. They are most prominent in the naive T cell. This is a diagram. You can see a common lymphocyte progenitor which enters the thymus, which is initially a double negative, and once it undergoes variance, diversity, and joining, first rearrangement after that it will form the signal joint tract, which is used for the NBS for SCID. Then after that second rearrangement it will form as coding joint tracts. These are more prominent in the naive T cells, which is inactive cells. Once they get expanded and becomes the active cells, which will get diluted, but it won't get lost during the divisions like mitosis and meiosis. So it can be very helpful. And once there is a mature T cells are there, since they are active cells, there will be less tricks. It's mainly picked up by the real-time PCR. The healthy terms usually have a level greater than 1000. In SCID, the levels will be as low as less than 30. They have based on monthly and year-wise reference ranges, and based on the laboratory reference range also will be there. And the absolute cutoff they have taken is less than 30. The extensive systematic review has been done, which showed a sensitivity of up to 100%. TREC can also be low in where there is will be T cells also will impair, like trisomy 21, DJAR syndrome, trisomy 18, ataxia telangiectasia, and CHAR syndrome. Can be false positive in preterm neonates since they will have less production of MS and T cells. So in preterm we should be cautious and should be want to repeat the test after 37 weeks. Into the diagnosis, the absolute values of T cell, B cell, and NK cell by flow cytometry should be needed. Once we suspect a thing, first we want to know about the absolute lymphocyte count, and after that we go for the T cell, B cell, and NK cell. And also there is analysis of naive cells like CD45 and RO1. These things are mainly for CD45 RO is mainly for the naive T cells, which can be used in Oman syndrome. In Oman syndrome, there will be reduced the naive T cells, but there will be autoreactive T cell pool will be produced. So the numbers will be about nearly normal, but naive T cells will be reduced. And CD45 RA, which is mainly for the adult T cells. So if there is suspected maternal T cell engulfment syndrome, where we can do CD45 RA also. So we know about it can be the cause. Then we want to go for the immunoglobulin profile and mitogen proliferation studies for functional testing, and imaging for thymus meanwhile if required, and mutational studies. This is the thing. Once you want to detect early means you want to go for a NBS screening if it is positive, or if you're suspecting a PID, we should go for absolute lymphocyte count. If you are ordering a NBS screening with TMS means we can detect ADA deficiency as early also. And next, if it is confirmed if there is a low absolute lymphocyte count, then we should go for lymphocyte subset analysis. We should include both CD45 RO and RA, where Oman syndrome also can be a possible, and lymphocyte mitogen proliferation test if available. Then immunoglobulin profile. Then we want to go for mutational studies and for confirmation of AD and PNP. we can go for the AD and PNP levels. This is a flow diagram. In this, if you're suspecting a T cell SCID, there is a B plus or B negative. If there is a B plus means then we should divide for NK plus or NK negative. If NK plus means it is a X-linked SCID, and if you use autosomal recessive means there will be JAK3 mutation. If NK is negative, you can go for IL-7A deficiency. If there is a B negative means in our case it was a B negative, then we should see for NK is negative or low or NK is present. If NK is negative or on the lower side of normal, only two differentials are possible, where the ADA deficiency or PNP deficiency. PNP deficiency, we can have additional low uric acid also, which can be done bedside. And if NK is positive, then we want to go for autosomal recessive RAG1 and RAG2 mutation. So in this babies, since in our babies the NK level is near to normal, near the lower limit of normal, so we plan for a next generation sequencing, which also we want to see about the RAG1 and RAG2 mutation also. Coming to the ADA deficiency, it is a metabolic disease of human system, so variable severity depending upon the residual activity of the involved enzyme. The ADA enzyme is responsible for the purine metabolism, mainly for the breakdown of DNA byproducts. It is found in all.
Hello. Got cut.
Sir, yes, just now joined, sir. Rejoined. Yes, last signal.
Okay.
Okay. ADA levels are mainly most active in the lymphocytes. If the ADA levels are inadequate, there will be toxic accumulation of 2-deoxyadenosine, which will the rapidly dividing immune cell and cause cell death and progressive lymphopenia. Nowadays, the tandem mass spectrometry, which also can be helpful to pick up the ADA deficiency, which is involved in the expanded NBS program. And there are also late onset clinical disease, since ADA shows variable severity based on the involved enzyme. If there is untreated, we can have the other characteristic signs like rib flaring, liver toxicity, sensory neural deafness, and neurobehavioral problems. This is the Omen syndrome. It is a variant of SCID in which there is a very low number of naive T cells, but they expand in the periphery as a oligoconal autoreactive pool. These patients mainly present as a severe dermatitis and colitis, which usually develops week after birth or after a viral infection. This may be additional to the supportive therapy like immunoglobulins and antibiotics. It needs immunosuppression also. For this, we need to do CD45 or RO. This is a case report which has been published in the 2018 in the American Journal of Perinatology. In this, the child presented at 1 month with erythroderma, severe infection and failure to thrive. Since the baby had dermatitis and also had absolute lymphocyte counts below the normal limit, they worked up further and they thought of a Omen syndrome also. In that, they found it as a RAG1 mutation and CD45 RA was reduced. So they labeled as a Omen syndrome. The baby improved and they successfully done the hematopoietic stem cell transplantation. And this is the newer classification based on the babies who received the HSCT for the SCID. So they classified as a classical SCID if there is a T cells less than 300 with less than 10% function, or there is presence of maternal T cells. If the Omen or leaky SCID where there is T cell levels will be 300 to 1500 and the function will be about 10 to 30%, the known SCID gene mutation. There is variance. SCID is similar like Omen without underlying gene mutation, and we have syndromic SCID like DGARG, Down syndrome, and CHART syndrome. The treatment, we have a supportive and definitive treatment. The supportive treatment is like IVIG, mainly for the immunoglobulins levels. We should maintain a immunoglobulin G level with a tough level of up to 500 to 800 milligram, that is upper limit of normal. And we need to start the baby on Septon prophylaxis and also like antifungal and antiviral prophylaxis. And blood products and live action should be given cautious, since blood products should be irradiated and lymphocyte depleted, since there will be graft versus host response also based on the T cells from the donors. And live vaccines, we have a lot of case reports like BCG disseminated infection and oral polio disease also. So it should be cautious since there is no T cells. So the definitive treatment is HSCT. If it is done less than 3 months or without the active infection, the survival rate is about 95%. But if beyond that, if the infection has acquired on the later ages, it will be only up to the 50%. And the main donor is like HLA matched siblings or the